Hello, my name is Tim Bateman. I'm co-director of cardiovascular radiologic imaging at the Mid-America Heart Institute and the St. Luke's Health System in Kansas City, Missouri, and professor of medicine at the University of Missouri Kansas City School of Medicine. Dr. Gary Heller, as chair of the PET task force within the American Society of Nuclear Cardiology, has reached out to our program to present two educational cases focused on PET and specifically on the relationship between image appearances and blood flow reserve as well as ventricular function. Dr. Faraz El-Badaren is a cardiologist who works at our institution, specializing in outcomes analysis, and he has worked up these two cases for us. I'm going to ask Faraz to introduce himself briefly to you all at this point in time.
Thank you, Dr. Bateman. My name is Faraz El-Badaren, a nuclear cardiologist and outcomes researcher. I had the opportunity to prepare and hopefully to present the following cases, and I hope to highlight certain features and utilities of myocardial blood flow in routine clinical practice. The first case is about a 58-year-old male who presented to the clinic complaining of atypical chest pain with occasional neck involvement. Pain does not appear to be related to exertion. While the patient does not have history of coronary artery disease, he has multiple cardiovascular risk factors, including hypertension, hyperlipidemia, and active smoking, and he is on several medications, including aspirin, lisinopril, spironolactone, and rosuvastatin.
So, Faraz, what makes this particular patient a good candidate for a PET study as opposed to some other type of evaluation?
Yeah, as we approach these cases in routine clinical practice, you want to try to answer multiple questions, hopefully with one test, and you will reach out to the modality that will give you most of the information that you're looking for. So the questions we have at hand here is, number one, is his chest pain caused by coronary ischemia? The other questions that are, in my opinion, equally important, what about his long-term cardiovascular risk, any additional information that we can obtain about subclinical atherosclerosis and so on. So while other imaging modalities may answer the first question, I do believe that a vasodilator PET provides additional information which can help us risk stratify and inform management for this patient. So therefore, the patient went on for a rest stress vasodilator PET. He received a regadenoson, and the study was performed on a PET-CT system. He received a dose of 35 millicuries of rubidium for both the rest and the stress acquisitions, and he went on for image interpretation. As you can see, just to orient the audience, we have stress up top and rest at the bottom. So stress and rest, and as you can see, there is homogeneous radiotracer uptake throughout the myocardium without any evidence for fixed or reversible perfusion defects. So
these are 3 millimeter thick slices, and they are immediately adjacent to one another with no spaces in between them. And the impressive thing in my mind is just the count density is so rich in these PET images. Now, the other thought I have when I'm looking at these is that in this particular case, there is very avid uptake of the radiotracer in subdiaphragmatic structures. I wondered if you wanted to comment on that.
Sure. While this is not a very frequent occurrence, we don't see it very frequently. When it does happen, given the characteristics of PET, we are still able to differentiate between adjacent extracardiac activities and the inferior wall due to the built-in attenuation correction and scatter correction and the high image resolution. So even though in certain situations when we run into these findings, we are still able to confidently and reliably comment and interpret the inferior wall and all the myocardial segments.
So at this point in time, looking at these images, they certainly appear normal. Would you be comfortable? Would you be confident to say that this is now a normal study, or do you need more information?
This is one of the beautiful things about working with an imaging modality such as PET. It allows you to, in addition to obtaining relative myocardial perfusion assessment, it also gives you the opportunity to assess left ventricular function at peak stress, and also gives you the opportunity to evaluate myocardial blood flow, which we will move on next.
Well, let's stop and let's look at function before we move on to blood flow. And what do these function images tell us?
So, again, if you look at the top line, shows stress, function at stress and at rest, and due to the way PET protocols work, image acquisition happens at peak stress, which enables you to assess and evaluate left ventricular function at peak stress. And as we all know, hyperemia is a potent inotropic stimulus, and it results in improved left ventricular ejection fraction, which by itself has valuable diagnostic and prognostic information.
So in this particular case, the ejection fraction was computed to be 69% at rest and 74% at the peak of stress, and I understand that you are telling us that this is a normal response?
I agree. I concur. This is a normal response where you see improvement in left ventricular ejection fraction under hyperemic conditions.
Okay. And if you saw the opposite, if the ejection fraction dropped?
When we see a drop in ejection fraction, that has been shown to be highly associated with presence of high-risk angiographic disease, including left main or three-vessel disease. So the failure of the left ventricle to augment function in response to hyperemic stress might indicate the presence of severe or extensive coronary artery disease.
All right. Well, thanks. That's very helpful, and that is quite different from the way we look at function assessment with SPECT. Correct?
Correct. Where in SPECT you obtain images post-stress, typically anywhere between 45 or 60 minutes, depending on the stress modality used. And then by that time, most of the augmentation in left ventricular ejection fraction that might be seen has normalized, and we missed that opportunity to assess LVEF at peak stress.
All right, let's move on to blood flow assessment.
Okay, so as with any other test, you would want to do some quality control at the beginning to be able to make sure that you have reliable data you are working with, and that the interpretation will be valid and helpful. If you look at the left-hand side of the screen, I recommend that we start with some quality control by looking at, first of all, making sure that the myocardial territories are well demarcated and that you are not including any adjacent cardiac activity which may lead to erroneous flow values. Second of all, proper positioning and consistent positioning of region of interest for the input function between rest and stress should also be verified. getting into the habit of reviewing the time activity curves, making sure there are no multiple peaks or broad peaks, which may indicate problems with the infusion or problems with patient motion, also helps you verify that you are working with reliable data. And in general, you want to check for the rate pressure product and correct the resting values for that. And you want to make sure the patient doesn't have any cardiac shunt or severe regurgitant lesions, all of which may affect the accuracy and the integrity, the fidelity of the readings, if you will.
Sure. Very good. The other very important point, of course, is that that you learn from these time activity curves is that you really have to start imaging prior to the tracer arriving at the region of interest from which the input function is going to be derived. So you always must have this time lag prior to seeing the rise in the activity level. So what do you think of these resting blood flows? In other words, average 0.66 ml per gram per minute and about equal in all three coronary territories at rest.
This is considered acceptable and within normal limits. The three territories, as you have mentioned already, they are there's homogeneous myocardial blood flow values. The global rest myocardial blood flow is 0.66, and this is with rubidium, so this is considered within the normal range, 0.6 to 1.2, depending on the reference. So these are acceptable flow values. If you look at the panel right above it, you see that myocardial blood flow has augmented in all three territories to a similar extent, with a global myocardial blood flow at stress of 2.1 and a reserve of 3.2, both of which are considered in the normal range. So in addition to having normal relative perfusion, we are dealing with healthy myocardial blood flow at rest with proper augmentation, attesting or indicating intact coronary vasomotor function and normal coronary flow reserve.
Okay, so tying it all up, what do you conclude from this study?
This study was interpreted normal myocardial perfusion at rest and post-stress with normal left ventricular ejection function, segmentally and globally. Peak ejection fraction was 74%. Myocardial blood flow was normal at rest with proper augmentation in all three territories and a myocardial flow reserve of 3.2 times normal.
Okay, so compared to SPECT then, which obviously would give us normal myocardial perfusion at rest and at post-stress in this case, I think, if it was done with attenuation correction, and it would also show us normal ventricular function, probably at rest and at post-stress, as you point out. But in addition, now we have something else that takes us away from the problem of spatial relativity, which is the normal myocardial blood flow reserve that really cinches that this study is completely normal.
I totally agree. And this is the value where you tie in the different parameters that we can obtain from PET. So with a myocardial flow reserve of 3.2, that makes the possibility of having any high-risk coronary anatomy, including left main or three-vessel disease, extremely unlikely. This has been shown in prior investigations with a very high negative predictive value for intact myocardial flow reserve. The second piece of information we can glean is the excellent prognostic outcome of somebody with this set of findings. Prior investigations have shown that even if you have normal relative myocardial perfusion pattern, the presence of normal or abnormal coronary flow reserve differentiates the intermediate and long-term outcomes. In this particular patient, having normal perfusion and normal myocardial flow reserve identifies a group of patients with low event rates, whereas if they had normal perfusion but abnormal flow reserve, that identifies a six-fold increase in events in the short and intermediate term.
Sure. Okay, very, very important how you tie all of this together. I would add that a drop in ejection fraction between peak stress and rest, very important indicator of a problem. An augmentation of ejection fraction obviously places a patient in a completely different territory from a drop. But I believe that because these vasodilators do also dilate people peripherally, that you could see an augmentation of EF and need to be a little bit careful about the meaning of that. And I'm just going to poke you a little bit here and say, what if this person's blood flow reserve turned out to be 1.1, but the ejection fraction still rose? How would you, what would you be thinking about with basically no augmentation of blood flow?
So the possibilities here would be either vasodilator under-responsiveness or non-responsiveness. It will be difficult or it will be a little more challenging interpreting the rise in the ejection fraction in that situation. Somebody with caffeine on board or other antagonists of coronary vasodilators might end up in that situation. The presence of severe, extensive microvascular dysfunction might also give you blunted myocardial blood flow, but probably not to that extent.
Right, exactly. So the latter situation I just brought up because we sometimes see that in patients who come to the ED with chest pain and they are not properly prepped for a test like this. They may get anything from nitrates to beta blockers in the ED, and they may also have had lots of caffeine prior to coming to the ED. And sometimes we can see no augmentation at all of blood flow. Well, let's move on to your questions.
So the first question we've prepared for the audience, which of the following statements about non-invasive assessment of myocardial blood flow is incorrect? Number one, or A, impaired myocardial blood flow reserve is associated with increased risk of cardiovascular events only in the setting of abnormal relative MPI. B, blunted myocardial blood flow reserve may indicate unresponsiveness to coronary vasodilators or recent use of caffeine. C, abnormal myocardial blood flow is seen in patients with chronic kidney disease and those with prior coronary artery bypass surgery. And lastly, D, myocardial blood flow reserve may be used as a marker of coronary microvascular health.
All right, and you've said that the correct answer here, which is incorrect, is that impaired myocardial blood flow reserve is associated with increased risk of events only in the setting of abnormal relative myocardial blood flow. Do you want to say a word about that?
Yeah, sure. Prior studies, even though they were done with ammonia, have shown clear separation of the Kaplan-Meier curves by the status of coronary flow reserve. So regardless of your relative perfusion status, having an impaired myocardial flow reserve portends worse prognosis in either group, and it was prognostic in both groups of patients.
Okay, so it carries independent as well as incremental information over both. We've already talked about unresponsiveness. Obviously, some patients with chronic kidney disease, some patients with prior bypass surgery may have abnormal myocardial blood flow just because of the pathophysiology that is involved with those cases. But sometimes you see completely normal myocardial blood flow reserve as well. And there are studies to indicate, particularly with chronic kidney disease, that there is important prognostic information in blood flow reserve. Okay, and now your second question.
Which of the following may affect the accuracy of resting myocardial blood flow quantification? A, significant patient motion. B, erroneous localization of the myocardial blood flow input function. C, severe valvular insufficiency. Or D, all of the above.
Why would patient motion potentially affect accuracy?
You can think about it. During the phase of dynamic image acquisition, you want the patients to hold still so that the area or the region of interest is captured. If they would move, or they, for example, have heavy respiration, or then the region of interest might be in and out of the underneath the scanners, and that may affect the counts and affect the myocardial blood flow calculation subsequently.
Okay. All right, just so then to wrap up this particular case, then you would say that even though this person has multiple risk factors, what you have established is normal perfusion, normal function response to a vasodilator stimulus, and completely normal myocardial blood flow reserve, thereby making any significant disease in the epicardial coronaries or in the microvasculature problematic. You've said the implications of this are important both diagnostically and prognostically. What do you think the implications are in terms of patient management for his multiple risk factors?
We have established the points that you just mentioned, all of them. We have established them with one test. So now that we go back and inform the patient that his chest and neck pain are less likely or unlikely to be caused by obstructive epicardial coronary disease, we have established that he has normal microvascular function, and would basically tell him, you are in a good shape today. Our job is to help you stay in a good shape, and would continue preventative medication and counsel him for smoking cessation. And the need for further testing is probably minimal to none.
Okay. You want to review these teaching points?
Sure. So as take-home messages, review of time activity curves helps identify technical problems that could potentially affect the accuracy of myocardial blood flow readings. Adequate flow augmentation in response to hyperemic stress indicates normal coronary vasomotor function. The presence of preserved myocardial blood flow reserve portends low risk of future cardiovascular events beyond what's obtained from relative perfusion assessment.
Great. Thank you so much. Okay, well, I'd like to thank Dr. El-Badarian for putting together this interesting case of normal myocardial perfusion with normal blood flow reserve.
Thank you, Dr. Baker.